Second half of our plastic and reconstructive surgery chapter, chapter 19, we start getting into some hand procedures. And as the slide shows, the hand anatomy is pretty extensive. There's some nice figures in the book that go through that anatomy. Wrist, palm, and fingers. There's your bones. Digits are phalanges. 14 phalanges in each hand for each joint of the finger. Good thing to know is there's about 40 muscles and tendons that are responsible for the movement of your hands and wrists and fingers. Some terms that you should know: the volar surface being the palm of your hand, dorsal surface the back of your hand, radial refers to the thumb side of your hand, ulnar refers to the medial side of your hand. Replantation. Now this is where we either have amputated a digit off or we've crushed a digit so bad that it's beyond repair and we have to do something to replace that digit. And we went over this in class with a toe to hand transfer, but as the slide shows, there are some things that when an injury happens to a digit, there are some things that affect that quite a bit. The extent of the damage, sometimes it can be twisted or pulled so bad that it's hard to fix those tendons and vessels because they've been stretched and torn. The other thing is the care of the digit that got amputated. If it was a clean amputation, needs to be cooled. Now I've been told that it shouldn't be put directly on ice, that it should be more like slushy ice water. It should not be in the direct contact of the ice. Also, how much time has gone by since the accident and the deterioration of that tissue. Some of the procedures for hands: subtotal palmar fasciectomy for Dupuytren's contracture. Toe to hand transfer we went over in class quite a bit. Centralization of radial dysplasia, that's for club hand. We'll talk about that a little more. Release of syndactyly. Syndactyly is webbed fingers or toes. We'll talk about that a little bit more later. And ablation of a radial thumb and collateral ligament. So Dupuytren's contracture can present itself in one of the three ways on the slide. It causes a deformity and contracture of the skin and the digits. So the contracture restricts the movement of the hand and forearm. What are our diagnostic tests and procedures for Dupuytren's contracture? They're going to be standard x-rays and, like most plastics, a history and physical with direct examination by the healthcare provider. On the slide are some of your instruments, equipment, and supplies. It's going to be supine with an arm board, or sometimes there's a special table that they'll use to slide in that slides into the OR table, called a hand table, and they will put the arm on that. If you're going to use a skin graft, make sure you confirm the donor site with the surgeon. Make sure you're getting that prepped in and draped in. Going to be a beer block or a general, more than likely. There's your prognosis and possible complications. Toe to hand transfer we talked about pretty good in class. One of the teams presented that case. And there's your preoperative diagnostic tests. Are going to be arteriograms of the hand and foot. Doppler, we're going to make sure there's good blood flow. X-rays to determine where the bones are. There's a bunch of your equipment. So, specialized to this procedure, Dopplers are not something we use every day, but whenever we're going to listen to vessels, we're going to use a Doppler probe. Vessel loops, for these they're going to use quite a few vessel loops because they're going to want to sling the nerves, the veins, and the arteries. So vessel loops come in a variety of colors: white, blue, red, there's even yellow ones. Position for this procedure will be supine with a hand table, or maybe sometimes two arm boards they put together to make up a hand table. Anesthesia for a toe to hand is going to be general. It's a very long procedure. There's going to be a lot of tourniquet time on this procedure, and those are things to be aware of. You're going to need two setups, one for the foot and one for the hand. They'll probably be working simultaneously, so you may have to tend to two separate teams working at the same time. The order of the anastomosis for a toe to hand starts bone to bone to keep ischemia time to a minimum. Then they do the tendons, then the arteries, then the veins, and then the nerves are last. And to be successful, as the slide shows, you need at least one artery and two veins to be anastomosed. Keep the blood flow going through the graft. There is a good description of the procedure in your book. It's quite extensive, as we noticed in class. When Manny presented this, I asked for a brief description, and he gave the full description, so that is what is in your book. Complications for this type of procedure are, if you don't get a good artery and two veins to this graft, reattachment is going to fail, and the tissue will necrose and it'll just die off. Also, decreased nerve function. These people are going to have extensive physical therapy to learn how to pinch and grip, and they're going to, if they don't perform all that physical therapy appropriately, their nerve function may not come back all the way, and they may not be able to pinch quite as good as they should. Centralization of radial dysplasia is a congenital defect called club hand, and the deformities can range from a hypoplastic thumb to complete absence of the radius. There's, as the slide shows, 5 different surgical procedures to correct it. Diagnostic tests and procedures are going to be x-rays and a history and physical with a direct visual examination by the healthcare provider, like most plastic surgery cases. So we want to correct the radial deviation of the wrist, and we want to maintain wrist and finger motion, and we also want the forearm to grow. So we're really just trying to improve all of the function in that extremity and correct that deviation of the wrist. K-wires will be placed in these. They get removed about 8 to 10 weeks after the procedure. And the patient is fitted with a splint that they can take on and off when they're having physical therapy. The patient should get better movement of their arm from this procedure. Syndactyly occurs when your digits in your hands or feet fail to separate and they become webbed with some skin. You may end up using a skin graft on some of these when they're fairly extensive. Again, this will be supine with the arm on a hand table if you're doing the arm. Anesthesia will be general. Dressing is removed 4 to 6 days, and movement of the digits is encouraged so that they don't scar down and lose their movement ability. Ablation of a radial thumb and collateral ligament. This is due to polydactyly. This is when you have a duplication of digits, and it's usually the 5th finger is the most common, but it can be on one side or on both sides, and they can be partial or complete digits. Sometimes they're just a little stump, and sometimes they are full digits. So there's your pre-op diagnostic tests and procedures, same as the other ones. Supine with the arm on a hand table, general anesthesia. What we want to do is restore normal hand function and provide unrestricted growth of that extremity. And we also want to provide a nice aesthetic or cosmetic appearance. And this procedure is usually done at 18 months, but they want to do it before they're age 5. They start getting into school, and this is something that can have psychological effects on kids if they have a deformity like that. So the thumb is immobilized for 4 weeks, K-wire is removed, splint is worn for 3 to 4 weeks, and you may need some physical therapy, probably not a lot, since it's more of a removal. Then we get into some breast procedures. And the primary function of the female breast is to produce milk, which provides nutrition and immunities to the newborn. In Western society, in particular, breasts are a symbol of femininity, and it creates self-esteem in women. Some of the procedures that we're going to go over are augmentation mammoplasty, tram flap, nipple reconstruction after breast reconstruction, and a mastopexy, which is done for breast ptosis. Augmentation mammoplasty is performed to increase the size of the breast or create a new breast after a mastectomy. Your equipment and supplies are on the slide. Make sure you have your implants at the institution and they are sterile before you start the procedure. Supine with arms on arm boards, local anesthesia with mild sedation, or a general. The implant is actually a bag that is made up of material that is inert to the body. So it's not going to cause a reaction if you put it in the body. They're available in teardrop or round shapes, and they are usually introduced empty and then filled to the predetermined size with saline. Incision options for these are the periareolar line, the inframammary fold, the axillary crease, or the umbilicus. They can tunnel them all the way up from the umbilicus. One thing about implants is they can make cancer diagnosis difficult. It's hard to see cancer sometimes with an implant in there in a mammogram. The pocket for the implant is put just underneath the breast tissue and often beneath the pectoralis muscle to anchor it. Sizers are inserted into the pockets and inflated with saline to determine the final size. The bed will be raised to a sitting position to allow the surgeon to evaluate the appearance of the implants. This is done in most places. Some places the surgeon will just step back far from the table and look at the patient laying supine to make sure they look symmetrical. While you're getting the implants up, the surgeon should irrigate the pocket with an antibiotic saline solution. With no complications, the patient is expected a full recovery with excellent results. If they have complications, it's usually scarring or infection. Tram flaps are done for breast removal due to cancer or other disease. This is psychologically devastating to women because they lose their self-esteem and they feel that they have lost some of their womanhood. So it has an effect on their self-image, and breast restoration is often done at the same time of mastectomy and may sometimes involve more than one procedure, with the nipple reconstruction as the final stage. If there's enough tissue, the implants can be done without tissue expanders. If they feel that they need to stretch the tissue, they'll put tissue expanders in and gradually increase the tissue until they feel there is enough tissue to cover the implant. Now, the flap reconstruction involves moving tissue from one side of the body to the other. So it can be taken from the abdomen, back, buttocks, or thigh. And there are two types of flap surgery. There's a free flap or a pedicle flap. A free flap, you totally remove the tissue and transfer it to the chest. In a pedicle flap, we're going to keep the blood supply attached and relocate the flap through a tunnel under the existing skin and into the chest. That flap will be mounted up to create a new breast. You can use the latissimus dorsi muscle or transverse rectus abdominis is the tram flap. If the reconstruction is done at the same time as a mastectomy, you need two setups, one for the mastectomy and one for the reconstruction. You don't want to spread the seeding cancer cells. You may use a Doppler to locate the major vessels in the flap. Again, diagnostic tests, they're going to be obtained by a history and physical and direct examination. There are some of your instruments and supplies on the slide. With no complications, these patients can return to normal activity in 4 to 6 weeks. If there's complications, maybe the supply of the flap is compromised, then that tissue is going to die. Some more equipment and supplies. You're going to possibly need sterile tattoo equipment for the nipple reconstruction. It can be done at the same time as the breast reconstruction, but sometimes they'd like to wait until that's healed well and the swelling has disappeared so that the breasts are in the right position before they reconstruct the nipple. That can be 8 to 10 weeks. Practical considerations for a nipple reconstruction: make sure you have the graft site confirmed with the surgeon, where you're going to take that graft from. Could be the upper thigh, inner thigh, maybe a labial fold. Just make sure you have that confirmed with the surgeon so the right spot gets prepped. These nipple reconstructions can take quite a while to heal, so it may take up to 6 months to get the right projection and sensation. They may repeatedly also want to color these to get the right color, so that may take more than one shot at the coloring of it. Mastopexy, the anchor technique, is performed to correct falling or drooping breasts. These can cause severe back problems and cause bra straps to be cutting into the skin, which gives a patient very long-term chronic discomfort. Preoperative diagnostic tests and procedures are going to be a history and a physical examination by the healthcare provider. Basic plastic stuff. Some of the techniques: a crescent lift, a Benelli lift, and a Benelli lollipop lift. Oftentimes, augmentation is done at the same time of the mastopexy, and the incision and the lift technique are going to depend on how much drooping has occurred in that breast. The incision is anchor shaped. It starts at the base of the areola and extends at an angle vertically on both sides and upward to form the boundaries where the nipple will be relocated. Same incision as a reduction mammoplasty. The patient's going to need someone to care for them for a couple days, but they'll have a full recovery and have excellent cosmetic results. Abdominal procedures. These are performed to enhance the patient's image of their body. So this cannot be confused with the paniculectomy, which is done to remove a big apron of fat on a formerly obese patient that's lost a large amount of weight. Common procedures for abdominal procedures for plastics are tumescent liposuction and abdominoplasty. Tumescent liposuction is performed to remove subcutaneous fat, and it's a cosmetic procedure, and we're going after those areas of the body that do not respond to changes in diet or exercise. It's that stubborn fat that just won't go away. So you need a minor instrument tray, large bore suction tube. The Mercedes suction cannula is a big honking suction cannula that's going to suck some of that fat and juice out of there. High pressure vacuum for the liposuction unit. And the medications you're going to mix would be a tumescent solution that has saline, 5% lidocaine with epinephrine, and whiteace. You may put an abdominal girdle on this patient afterwards, more than likely, to help reduce the edema. Supine position with possible repositioning. It's going to be general anesthesia or a local with some sedation. Surgical tech, if the solution isn't pre-mixed already for you, you'll have to mix the solution, and you have to be very careful to make sure you get the recipe correct. The normal tumescent mix is 250 milliliters of saline, 75 milliliters of lidocaine with epinephrine, and 2 milliliters of whiteace. Usually 30 cc syringes are drawn up and used throughout the procedure. You can use a blunt dissection technique. There's also a laser liposuction and an ultrasonic liposuction for different methods of doing liposuction. Abdominoplasty is performed to thin the upper abdominal fat and tighten the abdominal muscles, the rectus abdominis muscles. If you're not sure about what the preoperative diagnostic tests are, they're going to be a history and physical exam with direct observation by the healthcare provider. Supine position, general anesthesia. These can take 2 to 5 hours. It's kind of a longer procedure. It is considered major surgery. We're firming the abdominal wall and accentuating the waistline. The muscle is actually pulled together and sutured to tighten up that abdominal area. As you can imagine, we went over this procedure in class. These patients are going to be quite sore after this, and it may take them several weeks to return to normal activities. That's all we got for plastics. We'll see you in class.